consideration by the Cabinet Secretary. This year, the committee has agreed to undertake pre-budget scrutiny of the 21-22 budget, while also considering the impact on health and social care of COVID-19 on the current 2020-2021 settlement. The committee intends to take evidence from relevant bodies in August and September before hearing from the Cabinet Secretary for Health and towards the end of that. And at the first, in this series of meeting, we are hearing from senior leaders of the Health Service in Scotland. I'm delighted to welcome to the committee Eleanor Mitchell, Interim Director General for Health and Social Care in the Scottish Government, and Richard McCallum, Interim Director of Health, Finance and Governance. Welcome to you both. Can I start, as I think you know, we will hear from members in turn with questions that have been discussed in advance, but can I start with reference to the summer budget revisions and what else may be coming into the Scottish Government budget for health and sport in addition to that? I wonder if you could, if the witnesses can indicate what additional sums you expect to be allocated to the health and sport budget over and above the 620 million which was identified in the summer budget revisions. Eleanor Mitchell.
Thank you very much and good morning to the committee members. So I will pass over to my colleague Richard McCallum to provide further details on this. But so far, health and social care consequentials amount to £1.3 billion. And in addition to that, we expect further consequentials which relate to the £3 billion winter planning monies that were recently announced by the UK Government. But I'll pass on to my colleague Richard for the details on that.
That's helpful. Just to be clear, the 1.3 includes the 620 million, or that's already been identified. Is that correct? Yes. Richard McCallum. I wonder if we could have sound, please, for Richard McCallum. Perhaps we can come back to Richard in a moment if he's not able to connect himself from his end. It may be, Mr. McCallum, that you will need to unmute the microphone on your iPad. I'm not sure if you...
Can you hear me okay now?
Yes, please. Richard McCallum.
So thank you. Just to pick up from the points that Eleanor made, we have the summer budget revision was a point in time allocation of the 620 million. Since then, we've had confirmed funding of 1.3 billion, as Eleanor has commented. The big difference between the 620 and the 1.3 billion relates to PPE consequentials of 466 million, which have now been confirmed. In addition to the 1.3 billion, we have also had confirmation that there'll be further funding in relation to PPE, so we expect a further chunk of money in relation to PPE, but that hasn't yet been added to our Barnett scorecard, as it were, but we expect more. And as members will likely be aware, there was an announcement of winter funding in England of 3 billion. We expect consequentials from that of about 250 million as well. So we will expect that money over and above the 1.3 billion that has been confirmed. This will all be set out in the autumn budget revision in the next month or two, and that will have the detail, the more up-to-date detail that was included in the summer budget revision. That will set that out in further detail.
Thank you very much. And can I ask how decisions have been made on the allocation of this additional funding to different parts of the health service? Eleanor Mitchell.
Yes, thank you. Thank you very much. So I would outline two processes that we work through in terms of our governance arrangements. So within the Scottish Government itself, we set up a planning and assurance group, which was a group of the senior officials, including the clinical advisors and clinical leads, where we would take, we met very regularly, weekly, sometimes bi-weekly, where we would take decisions in relation to the prioritisation of funding that was coming through to us. Of course, this was in addition to the work that we did in ongoing close working with NHS boards, integration authorities, local government, and of course COSLA. The initial premise we were working on was the commitment that was given by the Cabinet Secretary that we would meet all reasonable costs in relation to the additional services that were required to be presented. So what the Planning and Assurance Group would look at on a regular basis was what the bids were coming in, what was required to be done, and how the allocations should be taken forward. There is a process which Richard can outline for you, which is the process through which we then release the funding to health boards and indeed to local authorities and through them to the integration authorities after their funding bids have come in. But Richard will want to pick up perhaps those more detailed points.
Richard McCallum.
Yeah, so I think in answer to your initial question, Convener, I mean, the key thing in terms of all the funding decisions that we're making is that we're doing them on the basis of the best data and evidence that we have available. So the decisions that we made in terms of the initial mobilisation about the capacity required in the system, all the funding decisions were to support the data and evidence that we had available at that time, and that continues to be the approach that we take. As Eleanor has said, we have a governance process that ensures that all spend is subject to scrutiny and approval by officials. Also, any spend over and above £1 million, which wasn't agreed as a part of the initial budget that we discussed with this committee back in February, would need approval of both the Cabinet Secretary for Health and the Cabinet Secretary for Finance. So that's the approach we've taken with all spend. With health boards and IJBs, that process has been in place from the start of the pandemic response. So we've asked boards to submit financial returns in the initial on a weekly basis to highlight the costs that they were incurring, and also to approve the requests of funding that were coming from health boards. And likewise, that has needed ministerial approval. What we will subsequently do on the basis of the costs that have been set out by boards is allocate funding on that basis. The allocation of funding will come once we've completed a full review of the costs in the first quarter, and then we will subsequently allocate funding to the health boards and IJBs from that point.
Okay, thank you very much. And finally, can you say whether, Eleanor Mitchell, can you say whether the additional sums allocated to the health service thus far have been sufficient to address the response to the coronavirus epidemic? Eleanor Mitchell.
Well, as far as we know, we have gone out to health boards, as Richard has said, and integrated authorities at the start of this. We asked them to estimate their additional cost requirements, and we're in the process of reviewing those returns. We have committed to fully funding this. The money has been allocated. Some money has been allocated. Additional monies will be allocated in the process that Richard has just outlined. So, as far as we're aware, as far as the information I have, that we are fully funding the requirements for both the integrated authorities and the health boards at this time.
Thank you very much. George Adam.
Thank you, Convener, and good morning, everyone. I would just like to follow on from what the Convener has already said with regards to, you've already said there was £1.3 billion worth of consequentials coming our way to the Scottish Government from Westminster. Has there been a situation where there may have been a commitment made down south with regards to health and the COVID crisis that we haven't actually received money for, or have we received absolutely everything in consequentials with regards to what they're spending down south?
Eleanor Mitchell.
Thank you very much. Richard is probably closer to detail on this. My understanding is that, as with all consequential arrangements, when monies are announced from the UK government perspective, we get our allocated share through the Barnett arrangements. The money that we have received so far a reflection of what's been spent in England, but Richard might have more detail on if there's anything I'm missing.
Richard McCallum.
Yeah, I think just two things I would maybe say. One, as Eleanor has said, where there is an allocation from HM Treasury to the Department of Health, then by extension there should be consequentials that naturally flow from that. And so we've had regular dialogue with Department of Health about that and Treasury to ensure that's in place and that's working as it needs to, and that dialogue has been effective. So I think in that sense, yes, that funding has been passed on. The second thing I'd maybe just add, though, is there are some areas of spend where an approach has been taken more on a four nations basis. So if we think about something like Test and Protect and some of the testing centres, the approach that's been taken has been on more of a four nations basis, and therefore the funding flows don't necessarily follow in exactly the same way. The costs will be incurred by the UK government for a testing centre, and therefore the costs associated with that wouldn't pass on to the Scottish Government as it would normally with consequentials.
Thank you. George Adam.
Well, with that in mind, Richard, possibly has it been possible for the Scottish Government to have the flexibility within the health budget to move money from to try and make sure that something that the Scottish Governments want to do is done? Has there been a flexibility within the budget arrangement for you to be able to do that?
Richard McCallum.
So I think with all consequentials, in health or otherwise, ultimately it's for Scottish ministers to decide how best to use them. Even whilst we've been talking so far about health consequentials, ultimately it's for Scottish ministers to decide, how they are allocated, whether they, in what sense. So there is that flexibility to do that, and that's what we would expect, and that's what we've put in place. Obviously, where there are kind of more of the spend on a four nations basis, like the testing spend that I mentioned, then obviously there isn't that same flexibility. But in consequentials terms, normally we would expect that flexibility to be there, to be used as the Scottish Government sees necessary.
Thank you. George Adam.
Sorry, Convener, I'm a wee bit out of practice since we came back. I should have said that was my final question.
Fair enough. Thank you very much. And I will then move on to David Stewart.
Thank you, Convener. Good morning, all. I'd like to move on to look specifically at Health Board budgets. How will the COVID-19 pandemic impact on the ability of Bourne over 3 years?
Eleanor Mitchell. I think that was a question about breaking even over the... Eleanor Mitchell.
Okay, thank you. I didn't quite hear the full question. Was it in relation to break even over the previous period? Yes. Yeah, so, okay, thank you. So, obviously the health boards in Scotland were put on an emergency footing at the outbreak of the COVID period in recognition of the particular circumstances facing us. So that kind of routine financial planning and development of savings plans were temporarily paused in the face of the immediate requirements to respond to COVID-19. As you would imagine, that would be absolutely the right thing to do. So as part of the work we're doing now on the remobilisation work, we're returning to look at those 3-year plans. Health boards, as a matter of routine, are required to submit their updated financial forecast as part of the Q1 review process. We'll be seeing some further submissions. From memory, I think that's the 14th of August, so pretty soon. We'll take stock at that point of the trajectories we've seen, what they're looking at this year, what they're looking at in future years, and we'll take stock of the situation then. But Richard may have more detail to add to that.
Richard McCallum.
Yeah, I think that's absolutely right, and I would just support the comments that Eleanor has made. I think just for the committee's awareness, I mean, our starting point will always be that the board should deliver in line with the plans that they set out at the start of the financial year. So as you'll recall, for 10 of the territorial boards, that was to deliver a balanced outturn, and with the 4 that were escalated for financial reasons, an improved financial trajectory on the overspends from previous years. And that will be our starting point, and that's what we'll be expecting those boards to deliver. As Eleanor has said, as a result of COVID, we expect that all additional costs in relation to COVID will be funded, and therefore we will be expecting that boards will continue to deliver to the trajectory that we set out. I think what we need to see and what we need to work through, having gone into this emergency footing, is just what the impact will be, both in the immediate and in the slightly longer term for the next 2 to 3 years. So as well as the allocation of funding to support the first quarter's costs, we will be looking to set a revised budget for the rest of the financial year for boards and make sure that they deliver in line with those plans. And see as well some of the opportunities that might come through COVID, possible efficiencies that might have presented themselves, which will help those boards that are needing to return to financial balance actually make some further progress in that respect.
David Stewart.
Thank you, Convener. Can I ask the witnesses, do you have any concerns about the financial sustainability of any boards in Scotland?
Eleanor Mitchell.
So at the moment, I mean, I think, so Richard is obviously closer to this. My understanding is that boards are largely showing variances from financial plans relating to COVID. The impact of COVID has varied across the country, of course, so some boards are spending more than others in relation to what they need to do. The work to look at this will be part of the wider assessment when we see the Q1 returns come in. But at the moment, no, I have no particular concerns about any particular health boards. As I say, the increase in spend is largely in line with COVID.
Richard McCallum.
So I think we have spoken before about the 4 boards that were escalated for financial reasons, and that was obviously pre-COVID. And one of the real focuses for us now, both in the months that we've just had, but also looking ahead over the remainder of this year and looking into the next financial year and beyond, is the particular impact for those boards that have been escalated for financial reasons. And I think, as I say, we are reviewing budgets and plans for the remainder of this year. We get information back from all boards on the 14th of August to show us what the financial trajectories are looking like for the rest of this year, and that will inform whether further interventions or further support is required for those boards. But at this stage, as Eleanor has said, we have a plan for all boards to review the costs related to COVID, and are confident that we've got the funding to support the additional challenges that have emerged as a result of this crisis.
David Stewart.
Thank you, Convener. I mean, that's all well and good, but the reality is that some boards constantly require brokerage just to break even. And then if you look at the January figures, 5 boards required an additional almost 50 million, including my own in Highland. It's not a real problem, but brokerage, does this not indicate to you they're not financially sustainable?
Eleanor Mitchell.
Thank you. I'll just pass that one straight to Richard. That's all right.
So I think in answer to the question of those boards, the thing that will give us confidence is that they progress along the plans they have to return to the break even. So for the 4 boards that are in that position, we have a 3-year trajectory for them to return to financial balance. And the question about confidence and sustainability will be clear, providing they can deliver in line with those plans. I think what I would say in terms of supporting that and giving some confidence, in the previous financial year, in 2018-19, the brokerage support was about just over 70 million. In 1920, that came down to 45 million for those 4 boards. So whilst they have their challenges, and we know that we are seeing that trajectory improve, and that's what will give us the confidence to ensure that they're on course to deliver financial sustainability moving forward.
David Stewart.
Thank you, Convener. And this is my final question. Could I move on to the pressing problem of the repairs backlog, which obviously is a capital issue? As the witnesses will know, in 2017, the last time I could see figures, there was an outstanding backlog of 900 million, of which 10% were high risk, 35% were significant risk. Obviously, we know with COVID, a backlog of repairs could impact on the effectiveness of infection control and cleaning. What assessment have you made about the chronic problem of repairs backlog, and what capital investment is needed by boards to resolve this pressing problem?
Richard McCallum.
So I don't have the exact figure to hand, Mr. Stewart, just on backlog maintenance, but the levels are at a similar range to what you've said from a couple of years ago, at about 900 million. I think that there is a kind of couple of things that I would say in particular in terms of responding to that. Some of it will be in relation to new investment that is going into the system, particularly in relation to the elective centres and the bed and anchor in Aberdeen, which will address some of the immediate concerns that there are in the regions that are affected, or regions that have those facilities coming on. So Ireland would be one example of an elective centre. So that would be one thing. We do have a programme of backlog maintenance reduction as well, and I'd be happy to provide some more details on the approach that we're taking to tackle the backlog challenge that we have.
Thank you very much. I'm sure that would be welcome. Can I now move on to Emma Harper?
Thanks. Thank you, Convener. Good morning, everybody. I'm just looking at our briefing papers, and it notes that the summer budget revision identifies an additional 164.3 million of spending on health interventions, but there isn't really any further detail about what the specific interventions relate to. And I know that health interventions are broad ranging from research, and especially if we focus on coronavirus as a #1 priority right now, I'm thinking about what we're needing to do to support rehabilitation, flu vaccination, test and protect, IT requirements across the whole country for GPs as well as for schools. So I'm interested in a wee bit more detail about what specific health interventions have been supported by this additional spending of 164.3 million that's been allocated.
Eleanor Mitchell.
Yes, thank you very much. I mean, I think it's fair to say that the scale of the challenges across the country and the level of uncertainty we faced going into this pandemic have been quite extraordinary. And you know, the way that frontline health and care services, and indeed my colleagues in this DG family and beyond, have stepped up and responded have been absolutely phenomenal. The scale of change we've seen in terms of what we've delivered has been also pretty remarkable. So, for example, we've set up community hubs across Scotland in relation to supporting COVID. That has been phenomenally successful in terms of making sure that the GP community were able to continue to work, focusing on the work they needed to do with the wider community, making sure that COVID positive patients were treated through a separate pathway. As you have said, we set up almost from a standing start the test and protect system and service, moving from having lab capacity at 2 hospitals in Scotland to each health board having capacity in order to undertake tests. We've rolled out near me programmes, hospital at home programmes. We've significantly reduced delayed discharge. We've shielded 150,000 clinically vulnerable people. We've mobilised the Louisa Jordan in order to undertake increased capacity as needed. And of course, we scaled up all the hospitals in order to respond to the degree of uncertainty. We weren't sure what was going to happen, so we invested significantly in ventilators and additional equipment just in case we needed it. We didn't need it in the event, however, we had a significant amount of planning and resource went into making sure that the NHS was very well prepared to deal with what was hit, what could have hit us. I mean, I could go on and on and on about the number of changes we've made and the things that we've done. It's been really quite remarkable. If it would be helpful, I'm more than happy to list those out and send a more detailed note to the committee for further perusal, or talk about any aspect I've mentioned.
Thank you very much. Again, a note to the committee would certainly be welcome, but I'll ask Emma Harper to follow up with a further question. Emma Harper.
Yep. Thanks, Convener, and thank you, Eleanor. I agree that the response that to COVID by everyone, whether they're National Health Service, the essential workers, all our volunteers, has been absolutely phenomenal. And I think that absolutely needs to be, sung from the rafters. I think it would be useful to have a wider list of interventions because it is very broad, and obviously there's a wide-ranging approach that we have had to focus on in order to tackle all aspects of this pandemic. I'm interested about maybe flu vaccination, widening access for more flu vaccine across the whole of primary school children, for instance, up to 12 years old. The nasal vaccine works for kids as well. I'm also just wondering if you're projecting that the amount that has been spent on these wide-ranging health interventions, will it be sufficient? Are you projecting that the demands that have been created by this pandemic means that more money will need to be directed elsewhere in order to continue to tackle this pandemic?
Eleanor Mitchell.
Thank you. So the work, a number of things I'll pick up in turn. So the vaccination programme, we are currently planning to do the single biggest ever vaccination programme for seasonal flu, in addition to extending to the groups you've mentioned, of course, extending downwards for the age group from over 55. So that's expecting about 2.5 million people. We're planning to roll that out from between now and the end of December. That will be a significant programme. We're working very closely with health boards across Scotland to make that happen. That's in advance, of course, of any plan for a COVID vaccination programme that will take place as and when the vaccination becomes available for use. That would be a significant and major undertaking to take place, which is why we are working very hard with Public Health Scotland and beyond to make sure that we have one of the legacies of this would be a world-class public health response system, which is something that we are determined to deliver for Scotland. In terms of the Test and Protect programme we have in place, we have indeed scaled up that work. We're now able to deliver over 13,000 tests in Scottish labs, as well as the 22,000 through the UK Lighthouse Lab in Glasgow. We have plans, of course, to scale that up if we need to. We'd also plan to scale up in terms of the number of chasers we have in place. We have an outbreak in Aberdeen City, as committee members will know at the minute, and we have been working very hard to respond on that, and we've done so appropriately using mutual aid and other arrangements across the various health boards, but we know we need to scale up in terms of the contact tracers. So there are a number of things that we're continuing to have to work on and continue to invest in to make sure that we are responding appropriately to the virus as it continues to be with us. We're also investing with health boards time, energy and attention on second and subsequent wave planning to make sure that we are as ready as we possibly can be, looking at a whole range of scenarios in terms of resurgence of the virus, outbreaks, potential second wave, subsequent wave, concurrent risks around flu and, of course, Brexit. So we are working hard across the board with a number of partners, not just health boards, local authorities and beyond, in terms of making sure that we are as prepared as we possibly can be for what's going to come over the horizon. I don't know if Richard maybe wants to pick up on the wider financial aspects of that.
Before I bring in Richard, can I just check, Eleanor, if I heard you right? Did you say 13,000 tests in Scottish labs plus 22, or 30,000 plus 22? And was that a daily figure for testing capacity?
It's a daily figure. It's 13,000.
Yeah, and 22. Thanks very much. Richard McCallum.
Just a couple of brief points really to pick up on what Eleanor has said, and going back to the initial question about the 164.3 million health interventions. Clearly, the costs associated with these things will be more than that. That was a point in time estimate, and so we are doing the work as we've already outlined to make sure that all cost forecasts for the various programmes that Eleanor has set out have got robust financial governance behind them, and that we've got subject to the appropriate budgetary challenge and control. So if we take the Test and Protect programme as an example, we've built up for each strand of the programme, for the testing, for the tracing, for the isolate and support, we've built up funding streams to support each area of those programmes of work, and have budgets in place to support them. So I think it's just to assure the committee that we've got robust financial processes in place to support each of the range of programmes that Eleanor has mentioned just a moment ago.
Thank you very much. I move on now to Miles Briggs.
Thank you, Convener, and good morning to the panel. I wanted to ask a number of questions with regards to delayed discharge. And we know back in 2015, the Scottish Government set a target of abolishing delayed discharge. Now, I wanted to ask specifically, we know that beds have been bought up during the COVID crisis. So do we know, in terms of resources allocated to that, and why were these resources not previously made available to abolish and reduce delayed discharge?
Eleanor Mitchell.
Thank you. I'll pass on to Richard the financials around all of that. I mean, the work that we have done since the beginning of the pandemic to significantly reduce the number of delays in hospital again has been quite transformatory. The work we've been doing is very much based on the principles around discharge to assess and home first, which are some of the main learnings we have taken from this. I think one of the factors that has made this such a success, I think, is the desire, the single focus, I suppose, the single focus and desire of all partners involved to make sure that people were as swiftly and as safely as possible moved out of a hospital environment into an alternative accommodation. And that has proved very successful. The numbers have gone down significantly, have started to rise again as increases to hospital admission have increased. But the work, I think, is testament to the determination and ambition of all parties who were involved in the work. Richard can pick up on the financials.
Richard McCallum.
Yeah, so just a couple of things to add to that. So as I've mentioned, boards and integration authorities have submitted kind of cost estimates to us for the first quarter. An initial estimate was a figure of around 50 million that was allocated to support reducing delayed discharge. We're working with the boards and IJBs through the quarter one reviews, which we've already mentioned, to review those costs. But that's the figure that we have been given so far, that the estimate for the first quarter to support that the reduction of that work.
Thank you very much. Miles Briggs.
Thank you for that information. So is it fair to draw a conclusion that previously resources weren't available to actually drive down delayed discharge, and it's only because of that additional resource now coming online that these beds have been able to be purchased. And going forward, I obviously am seeing increasing levels of delayed discharge because we're seeing capacity return. But are we going to try to learn these lessons to prevent people actually being continuously delayed discharged?
Eleanor Mitchell.
So part of the answer to the question, I think, has to be the way in which resources are distributed across the system. The cost of providing long-stay accommodation in the NHS is more than the cost of providing care home services, or indeed a bed in a care home. So the issue is about how the money is distributed across the system. I think one of the things we have learned through this pandemic is a greater understanding of how people, information, data flow through the system, an understanding of where how we can best support people at home or in a home environment. So I think there are many lessons we can learn. I think in terms of funding, as Richard has said, yes, we have this initial tranche of £50 million was allocated in terms of health and social care partnerships to support delayed discharge and other things, and further funding will follow from that. It's a matter of, for me, I think it's as much a matter of the distribution of resources as it is quantum of resource.
Miles Briggs.
Thank you. And I think, to really push this point home, I think it's quite clear that we were not then funding a policy to abolish delayed discharge, that we've been able to only see this because of that additional 50 million. Would that be your view as well? Because I think that's an important part of going forward if we're going to properly fund social care, to understand that potentially we haven't been actually making these beds available previously.
Eleanor Mitchell.
So, the benefit of hindsight is an astonishing thing, isn't it? And I think, there's all sorts of lessons we have learned as we've gone through this process. I mean, there have been, before we went into this, when I was director of, I can't remember the name of my director at the time, I think it was Primary and Community Health, we were working very hard with all health and social care partnerships, looking at what were the barriers to reducing the delays. Funding was one issue, but it was one of very many issues raised. There are cultural issues in there. There are issues around so, for example, I mentioned discharge to assess. That's something that was implemented in some parts of Scotland, but not all parts of Scotland, because of the way that hospital systems were run in terms of how discharge procedures were organised. So there are a number of factors. We've done a lengthy piece of work speaking to all 31 health and social care partnerships on lessons learned. I'm more than happy to share that with the committee if that would be helpful. But I mean, as I said at the start, I mean, the most significant issue was the joint commitment and shared sense of purpose. So everyone working towards that shared common goal of making sure that people were able to be released out of hospital into a home, their home or a home environment.
Thank you very much. Miles Briggs.
Thank you. My final question, Convener. I think it's important we learn this if we're going to actually carry forward this policy. But I wanted to return to specifically my own area here in Edinburgh, because historically delayed discharge has been really a significant problem here in the Edinburgh IJB. And you said at the beginning of this session, Ms Mitchell, that the integrated joint boards had been fully funded. So I wanted to ask, why in that case is my Edinburgh IJB looking to make £36 million of cuts to services? And given the problem we have here in the capital, how's that going to actually help drive forward the abolishing of delayed discharge for my constituents? And what's happening within Scottish Government to understand that that's an impossible situation for IJBs to be in?
Eleanor Mitchell.
So I'll pass on the detail of funding to my colleague Richard, but we have been working extensively with all health and social care partnerships to understand the funding issues that they're facing, the budgetary issues that they're facing, and making sure that indeed that all the funding, the additional funding, the £811 million funding that we have, Scottish Government has allocated to social care, is being passed on appropriately. But Richard can maybe pick up the very specific points on the Edinburgh Partnership and the funding issues there.
Richard McCallum, briefly.
Just a couple of things. So on the Edinburgh IJB, the funding that was allocated in 2021 was 23.6 million, an increase in the budget for the IJB, and so that is to deliver the services that have been set out. In addition to that, the IJB has received its share of the 50 million that we've previously mentioned. So I think that equates to about 4.1 million for the Edinburgh IJB. So certainly we have taken the steps to fund Edinburgh as we have done with all partnerships. Is obviously allocated via health boards and IJBs. On the particulars of the savings plans, boards, IJBs need to work through the plans that they have, but these should be done in a way that delivers the services that they're expected and have been set out. We're working closely with the Edinburgh IJB on a range of things to ensure that there is support there. We've provided some practical support, particularly on looking at the care at home model that's in place in Edinburgh and how that can be strengthened and operated differently with such a range of providers. So I think there's some specific actions that IJB needs to take, and we're working closely with them on that.
Thank you very much. Before I bring in my next colleague, I wonder if I could ask Eleanor Mitchell, overall, how the model of integration of health and care has functioned during the pandemic. Has it brought in new challenges or offered new solutions? And has the experience of the pandemic highlighted any areas for improvement in the structures in place for decision making and allocation of resources in and around IJBs? Eleanor Mitchell.
Thank you. From my perspective, I think integration has. I don't think we could have delivered what we have done without integration, without living and working within an integrated health and social care world, and that is certainly the views that's shared with the chief officers who I speak to regularly. They share my view that they couldn't have achieved what we have achieved without integration. I think the closer partnership working the closer partnership arrangements that we built over recent years between managers and professionals within health, across health and social care have been particularly valuable. If you look at some of the work, I'm sure we'll come on to care homes, but if you look at the work in terms of care homes, having local care home managers sitting within the health and social care partnerships, working very closely across and between social care and the health boards, that has proved absolutely valuable as we've worked to or strive to put our arms around the care home sector and support them very effectively. So I think the other aspect I would add to that was in terms of resourcing. I think being able to mobilise a whole system in terms of resources, and that's people resources, people as well as money. I think that has absolutely made a real difference in terms of our ability to respond to these very challenging times.
Thank you very much. And now bring in Sandra White.
Thank you very much, Convener, and good morning, everyone. Can I just pick up slightly, Convener, sorry, on the previous question that you asked? I think is really important because of the integration situation. I just wonder if it would be fair to say that integration has not fully been rolled out, unfortunately, but it's desperately needed to work along with COSLA, because obviously local councils and care homes, you have to have the capacity in these care homes. So would it be fair to say that the working closer together would be much helpful in regards to delayed discharge? And sometimes the barrier there is not having enough care home places.
Eleanor Mitchell.
I just wanted to ask.
Sure. Eleanor Mitchell.
Yeah, thank you. So, I mean, as I say, I talk to chief officers regularly, and they obviously are very much play a bridging role between local authorities and health boards, and they are very clear that the very important their role in terms of bridging the gap, bringing together mobilisation planning between what the local authorities are planning to do in relation to, for example, social care support, and what health boards are planning to do in terms of the work that they're doing with frail elderly has been absolutely fundamental to the system. And yes, of course, I mean, the integration, the legislation to deliver integrated health and care services is still relatively new. We're still working through some of the issues. Just at the end of last year, we were looking at joint accountability arrangements for health and social care partnerships. And I think what this pandemic has shown to me and to many others, that actually this can work, and it can work very successfully. And the more integrated ways of working we can deliver, the better for the people of Scotland.
Thank you, and thank you for allowing me to come in with that, Convener. I wanted to ask the questions on PPE, and I think you answered possibly my first question, basically when you mentioned about the £466 million, and then there's further monies coming forward. So my first questions were going to be, and if you have answered it, you can tell me. I don't know if it's completely updated or not, but basically, are these the updated figures that you gave us earlier on about the Scottish Government spending PPE, and the updated figures on the ban at consequentials received, as a result of spending in PPE? And my last question in that tranche would be, were sufficient funds available to purchase the necessary PPE?
Richard McCallum.
So there's a few points in there, and I'll maybe just clarify some things. So that the 466 million related to consequentials that we've received, and as I say, we expect to receive some more consequentials relating to PPE. So far this year, we've spent about 200 million in the first 2 or 3 months of the pandemic response on PPE, and we've approved a further 114 million just in the last month or so to take forward further spend. We expect, I suppose, there's about a minimum to require spend of about another 300 million on PPE to see us over winter, but obviously that's dependent on a few modelling scenarios that we're working through at the moment and continuing to do that. And the other strand that we're picking up is just what we will require by way of a PPE stockpile as well. So there's a few components to that, but as you've identified, the point about the 466 million for PPE, that will be used to support the PPE purchases that we need to make. In terms of the question about whether sufficient funds were available to purchase necessary PPE, so the answer is yes. I mean, we made the commitment early to National Services Scotland, who supply the PPE, both not just on behalf of health boards, but also PPE for social care providers as well. And we agreed at an early point funding for NSS to take forward the requirements for PPE. And I suppose the key point in all of that is that the NSS have never reached a point where we've run out of any stock. We've always had the stock available, even at the kind of height of the first wave. And the plan now is to make sure that for future waves, particularly looking ahead to winter, that we have the stockpile there that will allow us and health and social care colleagues to have the confidence that the PPE is there and available as needed.
Thank you very much for that. So, but basically, will we be getting further information to the Health Committee in regards to basically up-to-date figures in regards to the monies that's coming forward? And another question I just wanted in the back of that is, whilst we're told that there's an allocation of consequentials, is there a time lapse between when it's announced and when the money is actually given to the Scottish Government? And what do you do if there is a time lapse?
Richard McCallum.
In relation to your first point, Ms White, I mean, absolutely we can provide further detail in terms of the PPE projections and plans that we have and the spending plans. On your second point, yes, there is a time lag, and I think the key thing from our perspective is to ensure that there's a good communications and lines of discussion with both HM Treasury and also the Department of Health and Social Care. So Barnet consequentials only get added at certain points of time, but through the discussions that we've had with the Department of Health, and let's be honest, we knew that there was a need to make the purchases of this PPE, and so actually this was an area that we quite simply needed to prioritise in that early part of the pandemic response. So yeah, a bit of a delay in terms of full notification, but we made some decisions early to make sure that the funding was available and allow NSS to make the purchases required, albeit they had some stock as well, existing stock, but ensure that we had that stock available.
Thank you. So this didn't have an effect on you being able to purchase PPE with this time lag. Monetary-wise, the budget was there to be able to afford the PPE, or did you have to take it from some other part of the health budget to purchase it before you received the monies? Excuse me.
Richard McCallum.
So I think because in a sense, in financial terms, the costs will all be charged to this financial year, to the 2020-21 financial year, without going into hopefully technical accounting stuff. Because we knew that the funding would be coming, we were able to take forward some decisions with some confidence and some certainty with NSS that the funding, that the costs that they were incurring would be funded by the Scottish Government. I mean, I think I would just add as well, just in relation to your other point, Ms. White, that NSS, one of the strengths that we've had in terms of our response is that NSS is a national supplier for items of stock for our health boards. And so actually the supply routes that NSS had, existing supply routes they had, allowed us to actually respond very quickly. And one of the strengths, I think, of our approach has been that we have that one body that purchases on behalf of NHS Scotland, and that has allowed us to with good supply routes that they have, to respond as we've needed to.
Yeah, yes, I noticed the Scottish Government's report, which mentioned, I think it came out on the 5th of August, which mentioned that 17 million items of PPE were basically distributed across Scotland by National Services Scotland. So that was pretty speedy in that extent. So the other question I wanted to ask, we were using National Services Scotland, but also were able to procure locally as well and manufacture locally, and obviously internationally too. So what I wanted to ask was, when you take it, the working with the UK government and the four nations, was that, to what extent did that have in purchasing PPE, the economy of scale in that respect?
Richard McCallum.
So we've had good relations with the four nations throughout on PPE, and absolutely we've kept lines of communication up with colleagues in England, Wales, and Northern Ireland to understand what the various countries are doing by way of procurement, and we don't want to get into a position of trading off against each other, certainly with suppliers. It hasn't as such. I think in the initial, the Department of Health were quite keen to do that economies of scale purchase on behalf of all nations. But because of the good supply routes that we already have through NSS, and I think the feeling was the same in the other countries as well, what the approach we've taken more is, rather than us all buying items as one together, we've taken forward our own approach to buying stock, but we've worked on the basis of a mutual aid model. So if, for example, Wales or Northern Ireland or England have been running low on any item, then we would provide that, and when items were available, that would be provided back to us. So, for example, we provided Wales with about 1.2 million of the Type 2R masks. and subsequently when Wales had received their stock order, that was returned to us. So we've worked on the basis of having a mutual aid model, and that has worked, I think, relatively effectively over the course of the last few weeks and months.
Yeah, I'm reminded of the fact that, unfortunately, some of the appliances or PPE which England had acquired were absolutely no good either. So, whilst yet 4 nations, it was good to see the 3 other countries and 4 countries, doing their own piece as well. One of the questions I also wanted to ask was, is this my last question, Convener?
Yes.
Did you say?
Yes, it is.
Oh, I can put the 3 together. No. I'll ask you my last question. What are the ongoing costs of maintaining adequate stocks of PPE expected to be? And in this particular one, I have to say that we have built up stocks of PPE, and I must thank the Minister, Ivan McKee, for going out and getting stocks in as well. We've actually increased the volume of PPE. So on that, what are the ongoing costs of maintaining the level of PPE expected to be? My last question.
Eleanor Mitchell and then Richard. Eleanor Mitchell.
Thank you. I was actually going to come in a slightly different point than the question about the ongoing costs. I mean, Richard might want to see more. I would say we're still working to identify what our PPE needs will be, given the significant and extensive remobilisation planning we're currently undertaking. The only point I was really going to make was just picking up the point there that really I would just want to pay tribute to the fantastic and phenomenal collaborative effort that went into ensuring that we had appropriate and sufficient PPE supplies through this pandemic. Richard's already spoken about the 4 nations approach, which was very successful. But relatively early on, it was identified that we would pursue a kind of make and buy strategy, and then a number of we got over 2,000 responses from Scottish businesses who wanted to support and help in this way, and those arrangements with many of them continue to this day. I think it's really important to recognise that the collaborative effort, not just within the Scottish public sector. We distributed over 350 million items so far. That's across the acute sector, primary care and social care, and that it was a phenomenal effort, and everyone pulled together, not just public sector but private sector as well.
Thank you for that.
Richard McCann.
Yeah, so I think just to say that to come in on that, the buy and make sort of 2-pronged approach is central to our strategy moving forward. So to go to the initial point that Ms. White made about what's the long-term stockpiling and approach, then the kind of buy and make using the likes of Don and Lowe for fabric for PPE, using Alpha Solway for the masks, that is a kind of key part of our strategy for the stockpile. I mean, I think our key focus at the moment is to make sure that we have an adequate stockpile for the winter period, and then looking ahead into 21-22. I mean, one of the key questions, I suppose, is just how long the virus will be with us and how long we will need to use the levels of PPE that we have at the moment, and that's the modelling work that we're undertaking just now. So I think one of the key focus for us, and I've already indicated that I'd come back with some of the detail about the costs associated, but very much as part of that, what we're thinking is what will be required by way of a stockpile, and that's a key focus for the work right now, looking ahead to next year and beyond.
Thank you very much. I'm very conscious of time, colleagues. So I'm going to move now to Brian Whittle.
Thank you, Convener. Good morning to the panel. And community hubs have already been mentioned earlier on, and we know in the summer budget revision there was £35 million allocated to community hubs in response to the effects of COVID-19, specifically around trying to ease pressures on GP practices and hospitals. So can I ask in the first instance, Is there evidence there that you can provide and how effective they have been, specifically around perhaps the impact that the hubs have had on GP patient numbers?
Eleanor Mitchell.
Thank you. Yes, so since the 23rd of March, we've had over 130,000 contacts through 111. Of those, just over 30,000 were advised to self-care and 90,000 were transferred to the hubs. 8,000 were triaged to 999. So all of those people would have either gone to their GP practice previously or would have gone to A&E. So I think that the hubs in that regard have been very helpful in terms of managing the whole system, patient flow, and also making sure that people were getting the right care and attention as and when they needed it. In terms of formal evaluation of the hubs, we haven't had the chance to do that yet. Although we are hoping to build the use of hubs into our patient pathways going forward, particularly in relation to looking at how unscheduled care is managed and people are helped to access the right treatments right from the start.
Brian Whittle.
Thank you. I suppose following on for that, I think that you're saying the impact of the hubs has been effective. Do you think there's been sufficient funding provided to support the operation of these community hubs?
Eleanor Mitchell. Yes, I think there has been. I think we asked health boards, health and social care partnerships to give us their estimates of what running the hubs would be. The model, of course, was based on GP out of hours. We will get more information, as we said earlier, when we get the returns back in and we look at what people have done. As I said, we are looking to roll out the use of hubs into the way that we continue to deliver health and care services in Scotland. So as they become part of the way things are done, then we will get a greater understanding of the ongoing running costs of the hubs. But they have very much been part of our success story, I would say.
Brian Whittle.
Thank you. Just finally, Convener, I think I'd like to understand how much longer you think the COVID-19 community hubs are expected to be operational, at what cost. I think really interesting to your answer there was around looking at the ongoing benefits of this kind of approach and whether that this is something we can spill into other areas of NHS, looking for those efficiencies and maybe perhaps lessons learned in how we approach healthcare.
Eleanor Mitchell.
Yes, absolutely. I think this is so a number of aspects of lessons learned in relation to the hubs. In terms of the work with COVID, I mean, I guess COVID will be with us until we have a vaccine. So we would expect that we would continue to run these until for as long as we need to. As I said previously, they have been considered to be a success. They fit very well with the aspirations around phase 1 of the GP contract, which was ensuring that GPs were expert general medical practitioners, so they were working to see a greater acuity of patients. So the work of the hubs is very helpful in that regard as well. It also helps make best use of the multidisciplinary teams within primary care and making sure that all that it can possibly be done within a primary and community setting is done. So it also builds on the kind of Once for Scotland approach, which is looking to make sure that we are doing things as consistently as we possibly can across Scotland. So the numbers of hubs has fluctuated as we've gone through the pandemic, largely related to volumes, but it's something, as I said, that we are looking at in terms of the patient pathway, something we're very interested in looking at in terms of how we transform the delivery of unscheduled care. So that's access to people turning up to A&E, for example, when there are perhaps better ways of caring for them.
Thank you very much. David Torrance.
Thank you, Convener. Good morning, everybody. What timescale is the NHS Louisa Jordan expected to be kept operative? And what care is the hospital currently providing? Could it be used to provide a wide range of postponed non-COVID planned healthcare that has been delayed?
Eleanor Mitchell.
Thank you. I'll just pass that question on to Richard, if that's okay.
Yep, Richard McCall.
Yeah, so thank you. So we're working through options at the moment in terms of keeping the Louisa Jordan open for the remainder of this financial year. So looking at options to keep it open over the course of the winter period, and that really takes us to the kind of second part of your question, Mr. Torrance. The Louisa Jordan is obviously a national resource, and since early July, it's been providing a range of outpatient activity, particularly in relation to orthopaedics and plastic care for patients. It's been a pilot arrangement. It's been primarily NHS Lanarkshire that has been using it. We've also been using it. The National Education Services Scotland have been using it as an education hub, as a safe place for training, for staff development and etc. Support in those areas. So I think very much it's a resource that potentially can be used. We've spoken already in this session about the remobilisation plans that boards have and are submitting to the Scottish Government. And one of the things that we'll be looking at when we combine all of the remobilisation plans and looking at the modelling that has been done about potential future waves going into winter will be that very point that you say, how can we potentially use the Louisa Jordan, not just for the areas that I've already mentioned, but build it up to be used for other purposes.
David Torrance.
Thank you, Convener. What are the ongoing costs of running the NHS Louisa Jordan, and how do these compare with other hospitals?
Richard McCallum.
So I think the summer budget revision mentioned the cost of the Louisa Jordan of 27 million. We've finalised the kind of initial setup costs of that, and we think that's going to be about 31 million pounds that we've spent on the Louisa Jordan to get it kitted out and ready to be used. In terms of the ongoing running costs, there's a governance and oversight board for the Louisa Jordan. They're undertaking a piece of work at the moment, which is looking at the running costs that there are for the Louisa Jordan and what that potentially could scale up to over the course of the remainder of the year. I think they're due to publish that at the end of August. I'm just wondering maybe if the most helpful thing would be to provide that to the committee at the same time, so you have that information there. In terms of comparing it to other hospitals, it's quite difficult to compare it to a kind of traditional hospital where there's all the usual fixed costs that there might be. So there's not necessarily a direct read across, but I think two things I maybe would say on that. One, we have obviously kept in close contact with colleagues in Wales and in England in terms of the Nightingale hospitals. And actually, the costs associated with the Louisa Jordan are very much in line with the costs associated with the Nightingale hospitals in England and Wales, and we've been sharing best practice with colleagues on that. And I would go back to the work that Health Facilities Scotland have done as well. So again, a specialised body within National Services Scotland who've done a phenomenal job in terms of taking forward the work on the Louisa Jordan, sourcing it, kitting it all out, and at some speed. And I think with those kind of the appropriate governance and support for Health Facilities Scotland, that's ensured we've done it in the most financially prudent way possible.
David Torrance.
What preparations are underway for a potential second wave of coronavirus infection? With the investment in NHS Louisa Jordan, can you expand on what role it will have to play in any potential second wave?
Eleanor Mitchell.
Yes, thank you. So we have, in terms of planning, we have written out to the health boards, health and social care partnerships, resilience partnerships, setting out 3 potential scenarios of the impact of COVID-19. And we've asked them to consider and come back to us with their plans for mobilisation of health and care services in relation to those 3 scenarios. We've had some initial returns and we're working on further returns. The general assessment we need to make in terms of our preparedness will look at capacity, both in terms of the acute setting and in terms of social care services and in care homes. It will look at things like the issues we've just spoken about in terms of PPE, in terms of the vaccination programmes, both in terms of the seasonal flu and also potential COVID vaccinations. It will look at our requirement to continue to do test and protect, a broader testing strategy and surveillance for testing. So this is very complex. One of the things we have absolutely learned is that it was much easier to turn off NHS and care services such as those that we did than it is to restart them in a very safe way. So Louisa Jordan will be is part of the planning process in relation to that. Boards have been asked to think about how they might use Louisa Jordan in terms of the access to services and however it will be temporary, so that will need to be taken account of in their plans. So extensive work underway, which we are working through with boards and partnerships to make sure that we are as ready as we can be for what's to come ahead.
Thank you very much. David Charles.
And my final question, Convener. Has any additional funding been made available to support these preparations, and how will it be allocated?
Richard McCallum.
So yes, additional funding will be made available to health boards. In terms of the funding available, I've already mentioned the 250 million of funding for winter planning. We expect further funding on top of that, and we'll be using that to support some of the decisions that we make in relation to our response to the pandemic going into winter. In terms of how we allocate that to boards, it will be a process whereby the remobilisation plans that we've received from health boards will be reviewed, and we will be looking at the plans that the boards have in place, both the service operational plans, the plans they have to innovate and do things in different ways. And on the basis of the remobilisation plans that we've received, as I was mentioning earlier, we will be allocating a further tranche of funding to boards and IJBs, which will be the basis for which they take forward their winter plans. So that would be something that we will expect to do over the coming month or two, and certainly by the end of September, have that in place for boards to take forward their plans for winter.
Thank you very much. Alex Cole-Hamilton.
Thank you very much, Convener. Good morning to the panel. Thank you very much for coming to see us. I'd like to ask, as a starter, which areas of NHS Scotland performance have been most negatively impacted? And what action will be taken to restore that performance?
Eleanor Mitchell.
Okay, thank you. I should start off by saying that, of course, John Connochan, the Chief Executive for the NHS in Scotland, is unable to be here today, and he's probably better placed to answer the range of detailed questions around impact on the NHS. And I'm more than happy to follow up with any further detail on any of this as would be helpful. Clearly, we are working through that in some detail with health boards at the moment. But with the exception of the information on cancelled operations and on A&E performance, we really have very little data so far in any detail other than the build-up of things like electives that inevitably happened as these things were taken forward. The part of the work we have asked health boards to do within their remobilisation framework is to assess what the backlog of activity is, to give us their estimations of how quickly they can work through that safely, and we will plan on that. We will plan on that basis going forward. The other thing I would, one other thing I would add, we have set up an NHS mobilisation recovery group, which is a wide range of stakeholders, including the Royal Colleges, including the unions, including the care home sector and boards, of course, and various other representatives. And that group, I think it's met twice, possibly 3 times. I know it's meeting again on Friday. That group is working through in some detail the implications for both restarting, and that's about looking at the surge capacity we still need to protect, but also how we can safely restart services and make sure that we are taking a clinically based assessment or clinical based approach to make sure that we are doing the right thing by our patients.
Alex Cohen.
Thank you for that. Part of the pandemic response has seen the suspension of all non-urgent elective treatment. Can you give us an idea as to whether there's been a significant saving as a result of that pause? And then will there be any additional costs in dealing with that backlog as we see to be?
Eleanor Mitchell.
Well, I'll hand over to my colleague Richard, but as far as I'm aware, there's been no formal estimates of any savings made, and the reason for that is most of the costs of the NHS are actually fixed costs in terms of premises and staff costs, which obviously we have still continued to make. And as I said, that we are working through in some detail with each and every health board and associated partnership the backlog of work and what needs to be done to take this forward. But I don't know if Richard would like to add to that in terms of any financial information.
Richard McCallum.
Just to support that point, that's absolutely right. So whilst some staff have moved into different roles during the pandemic response, and so some of the if you like, the costs associated with the non-urgent elective care hasn't been spent in that area, it's in effect moved to supporting the costs associated with COVID. So there hasn't been that kind of offset of costs as such. In terms of your question about the additional costs of dealing with the backlog, that, as Eleanor has mentioned, will be what we pick up through the remobilisation plans. And I suppose just to make the point that it isn't just about the money as well. This will be about staff and building up services in a safe way and in a sustainable way. So we will work through those potential costs with the health boards, and that will give us the clarity in terms of the costs associated with the costs in dealing with the backlog.
Alex Cohen.
Thank you very much, Convener. I'd like now to move on to pandemic preparedness and the cost of that. We know from previous Health Committee evidence sessions during the COVID-19 inquiry that despite operations like Silver Swan and others, it was clear that we had a significant gap in our pandemic preparedness against the WHO checklist, in that while they were calling for testing, we weren't preparing for testing. Will we need to see a higher level of funding towards pandemic preparedness, particularly around testing for any future pandemics? And if so, what additional funding will be required?
Eleanor Mitchell.
So a number of things I mentioned earlier. One of the aspects that we are working extensively on is with Public Health Scotland is to understand what a kind of world-class public health response would be, given what we've learned through the pandemic. So and I've also mentioned the work that we have done to significantly scale up both our testing capacity and the ability of our labs to process all those tests. I guess the wider issues we would want to look at, and I'll bring Richard in for information on this, is the cost of maintaining, for example, a national stockpile of PPE and other medical supplies and equipment. We might need not just coronavirus or indeed flu in previous years. And I guess similarly in terms of health and social care services, the type and level of equipment and medical supplies we may or may not need in the future. But I'll pass that on to Richard in terms of detailed financial information.
Richard McCallum.
Thank you. Yeah. So on the pandemic flu stockpiles, I mean, it has been an active part of our budget planning in each and every year, even prior to the COVID response, and typically we've allocated somewhere between 10 to 20 million pounds for pandemic stockpiles. I mean, inevitably looking ahead, this is going to be a kind of key consideration of the funding that we're going to need to put in place for our stockpiling. I think all I can say at the moment is certainly we expect a budget for 21-22 later in the autumn, and this will be a kind of key part of our considerations is what will be required for pandemic flu stocks, and as Eleanor has mentioned, for other items of things like PPE. So that's something that we're actively considering for this spending review period.
Thank you very much. And finally, can I ask what the changes in service delivery that have arisen from coronavirus, can I ask which of those are likely to be retained as and when we get to the point where we're beyond the coronavirus pandemic? What changes are likely to become permanent? What are the financial implications, both in terms of any extra spending and any savings that might come from it? Eleanor Mitchell.
Yeah, so we've covered part of this before. So I think the community hubs are likely to feature in our future as part of our reshaping of access to unscheduled care. I think the work on Near Me and digital consultations will continue. I think the work on promoting faster, speedier discharge from hospital will continue. I think the work on a hospital home will continue. Pharmacy first. As part of a broader continuation of ensuring that as much as possibly can in terms of health and care delivery take place as close as possible to an individual's home. In terms of the finances of that, I'll pass that over to Richard.
Richard McCann.
So, yeah, I mean, I think inevitably with some of these things, we will be looking to take forward steps in the most financially sustainable way. And I think things like the digital technology that Eleanor's mentioned and the use of Near Me, there potentially is greater efficiencies here. I suppose the thing that I'm particularly focused on, though, and mindful of, given we've spoken about this before at this particular committee, is actually not so much whether things are cheaper or more expensive, but how do we make those shifts in spend in the most effective way. So we've talked about shifting the balance of spend, and we've provided evidence in the past as to how we're seeing that. What I'm quite keen to see is how through COVID that potentially can be accelerated, and actually that the funding follows most appropriately the patient pathways that we'll be looking to put in place. So for me, it's not necessarily simply a question of is it more expensive or is it cheaper, but how is the funding flowing and following the people as best to support the range of initiatives that that Eleanor has talked about, whether that's in digital, whether that's in relation to primary and community care, whether that's in relation indeed to social care and the transfer of patients from an acute setting. And these are all the things that we will be reviewing and taking forward as part of the mobilisation work that Eleanor has previously mentioned.
That's helpful. And can I ask Eleanor Mitchell if it's possible at this stage to draw conclusions about the cost of social care and how far those have changed overall and what the projections might be? Eleanor Mitchell.
Yeah, thank you. So there has been, of course, increased spend on social care, and we've committed £100 million so far in relation to the increased costs. As we've said before, we are expecting further information both through health boards and through health and the social care partnership plans to understand how that work will be taken forward. Some of those costs, of course, in relation to are very particular in relation to the COVID plan. So for example, in terms of the social care support fund, so that's ensuring that workers who would normally just have access to statutory sick pay have access to their normal levels of pay. If they need to self-isolate, that would be very particular to COVID. Other aspects in relation to additional levels of PPE, additional funding for deep cleaning, for example, that's very particular to the current circumstances we find ourselves in. So all those things need to be taken into account to understand what the ongoing requirement of costs of PPE post-pandemic will look like in our care sector. I don't know if Richard wants to add to that.
Richard McCann.
Not particularly. I think that's right. I think what we are undertaking now is some immediate decisions to help support social care to support the immediate response. What we need to do now and what we are doing now is actually what the longer term impact of that is. And I think probably we're not quite at the point yet where we can say how much the costs will have impacted on social care, but that's clearly something that we're going to be considering in some detail as we move forward in the coming months.
Thank you very much, and can I thank both Eleanor Mitchell and Richard McCallum for their evidence this morning, and also for the quite extensive list of further information that they've offered to let the committee have over in due course. I look forward to receiving that information and that will certainly assist us and inform our ongoing inquiry. So thank you very much to our witnesses. That now concludes the public part of this morning's meeting, and we will move into private session and resume on a different platform at 11:30. Thank you very much.